Thanks everyone for joining. As Kate mentioned, my name is Amy Recker. I'm with the Massachusetts Department of Public Health. Today we're going to be discussing multi-drug resistant organisms in long-term care, local epidemiology, and infection control response. Both Melissa and I have no conflicts of interest to disclose. Our learning objectives for today are to define Carbapenem resistant Enterobacteriaceae, or CRE, and other important multi-drug resistant organisms, or MDROs. We're also going to review the current epidemiology and burden of MDROs in Massachusetts and review infection prevention and control recommendations for MDROs in long-term care settings, including the use of enhanced barrier precautions, or EBP. Finally, we're going to access MDRO and infection control resources and support. So to start off, MDROs, or multi-drug resistant organisms, are bacteria, fungi, and other germs that are resistant to the drugs normally used to treat them. MDROs are of public health concern because they are difficult to treat, they spread easily in healthcare facilities, and once an MDRO enters the body, patients are often colonized or infected indefinitely. Additionally, infections with MDROs have high morbidity and mortality rates. The people most at risk for MDRO infection or colonization commonly reside in nursing homes and other skilled nursing facilities. When we discuss MDROs, we often mention both infection and colonization. Let's briefly review the difference between the two. Infection refers to when an organism is in the body and causing disease. Infection is typically associated with symptoms and often enters the body through wounds or indwelling devices, such as central lines and catheters. Colonization, on the other hand, is when an organism is found in or on the body, but is not causing disease. Colonization is not usually associated with symptoms, but it can go on to later cause infections. I also wanted to note that when we discuss infection control for MDROs, residents with MDRO infection and colonization are treated equally. Even if a resident is asymptomatic and only colonized with an MDRO, they can just as easily spread MDROs to others, and they are also at risk of developing infection themselves. It is important to adhere to infection control recommendations for both infected and colonized residents, especially because both infected and colonized residents can cause transmission as well as outbreaks, and residents can be colonized with MDROs indefinitely, for months or even years. Later on in this presentation, Melissa is going to walk you through an example of an MDRO outbreak in a nursing home. This is a real-life example, and the index case was an individual who was asymptomatic and had been positive for CRE 2 years prior to the outbreak. In Massachusetts, our target, or high-priority MDROs, are CRE, Carbapenem resistant Enterobacteriaceae, CRAB, or Carbapenem resistant Acinetobacter baumannii, CRPA, or Carbapenem resistant Pseudomonas aeruginosa, C. auris, or Candida auris, and all Carbapenemase producing organisms, or CPOs. Let's dive into each of these deeper. First, let's discuss CRE. CRE stands for Carbapenem resistant Enterobacteriaceae. Let's break that term down, starting with Enterobacteriaceae. Enterobacteriaceae are a family of gram-negative bacteria found in the gut that includes E. coli, Klebsiella species, and Enterobacter species. Carbapenems are a class of antibiotics that include ertapenem, meropenem, and imipenem. Carbapenems are usually considered the last resort for some infections and are reserved to treat serious and particularly drug-resistant infections. CRE are Enterobacteriaceae that are resistant to one or more carbapenem antibiotics, meaning that patients with a CRE infection can't be treated with carbapenems. One way that Enterobacteriaceae and other bacteria are resistant to carbapenems is by producing enzymes called carbapenemases. The term CP-CRE stands for Carbapenemase producing CRE. So what are carbapenemases? Carbapenemases are enzymes carried by some bacteria that can break down and resist many classes of antibiotics, including carbapenems. Carbapenemase producing organisms, or CPOs, are of great concern and are very difficult to treat. Additionally, the genes that program a bacteria to make a carbapenemase can be shared between bacteria and mobile genetic elements called plasmids. The most common types of carbapenemases in the US are KPC, NDM, VIM, OXA-like, and IMP. These acronyms generally are derived from the place where they were identified. For example, NDM stands for New Delhi metallobeta-lactamase because it was first identified in New Delhi, India. Examples of carbapenemase-producing CRE are KPC E. coli or NDM Klebsiella pneumoniae. The CDC recently updated their antibiotic-resistant threat report in 2019, and they included CRE as an urgent public health threat. Now let's discuss some other multi-drug resistant organisms, several of which are also considered urgent threats in the CDC's latest report. Other bugs, besides Enterobacteriaceae, can also be resistant to carbapenem antibiotics. They can even be carbapenemase producing. These include crab, or Carbapenem resistant Acinetobacter baumannii, and CRPA, or Carbapenem resistant Pseudomonas aeruginosa. These bugs are being monitored by the Massachusetts Department of Public Health and are of public health concern as well. Another MDRO of public health concern is a multi-drug resistant fungus called Candida auris. Candida auris can cause severe illness in patients. It persists on healthcare services and has been causing outbreaks in hospitals and nursing homes throughout the United States. New York, New Jersey, and Illinois have been particularly affected. Fortunately, there have been few cases reported in Massachusetts. As of December 31st, 2019, only 11 cases have ever been identified in a Massachusetts facility. Now let's discuss the current activity and epidemiology of MDROs in Massachusetts. Here's a breakdown of the carbapenemase producing organisms that we've seen from 2017 to 2019. As you can see, KPC and NDM are the most commonly identified in Massachusetts, and incidence of both of them has been rising since 2017. And here's a breakdown of KPC, NDM, and OXA-like by organism. As you can see, E. coli, shown here in red, and Klebsiella pneumoniae, shown here in green, are the most commonly identified organisms. MDRO transmission was identified in 11 different facilities in 2019, including 6 long-term care facilities, 4 acute care hospitals, and 1 long-term acute care hospital. In 2019, 19 NDM-positive colonized individuals were identified through contact screening in 5 different facilities. In total in 2019, 850 screening swabs were collected at 82 different facilities. Contact screening, where indicated, has been critical to identifying and controlling transmission of these organisms. Already in 2020, we have identified 3 more NDM cases in a single nursing home. Now I will take you through infection prevention and control for multi-drug resistant organisms. So how are MDROs spread? MDROs are usually spread person to person through contact with infected or colonized people, particularly contact with wounds, urine, or stool. MDROs can cause infections when they enter the body. They often enter through medical devices like ventilators, intravenous catheters, urinary catheters, or wounds caused by injury or surgery. A comprehensive MDRO infection prevention plan is composed of many pieces. First, hand hygiene, including education and monitoring, which would include audits and feedback to staff, appropriate precautions and use of personal protective equipment, or PPE, including keeping the appropriate supplies stocked, education, and audits with feedback to staff. Staff education on MDROs and infection prevention, including audits and demonstrating competencies, housekeeping or environmental cleaning, again including appropriate supplies in stock, monitoring, and education, which would also include audits and feedback to staff, ensuring appropriate antibiotic use in your facility, including implementing an antibiotic stewardship program, and communication, especially having protocols in place to communicate residents' MDRO status with other facilities upon transfer, both verbally and in writing. Now let's review the process of when an MDRO is identified in your facility. First, your lab would identify an MDRO in one of your residents. Let's say an Enterobacter cloacae resistant to meropenem. Your lab would then notify both the Massachusetts Department of Public Health and your facility. MDPH will request that the isolate, if it meets submission requirements, is sent to our lab for testing, where we will test for a Carbapenemase gene target. So that would be KPC, NDM, VIM, IMP, or OXA. While testing is being performed, MDPH contacts your facility and shares initial MDRO infection control recommendations, which we will review on the next slide. Once the MDPH lab finishes Carbapenemase testing, we will contact your facility with the results. If it's negative, then likely no further action is needed. Your facility will just continue the MDRO infection control recommendations. If it's positive, for example, if the Enterobacter cloacae isolate tested positive for NDM, then MDPH may recommend implementing additional control recommendations depending upon the situation. Once a resident infected or colonized with an MDRO is identified in your facility, several infection control measures should be implemented immediately, including implementing the appropriate precautions, which Melissa will review in more detail, reviewing and auditing use of PPE, and placing door signage outside of patient rooms as needed. Hand hygiene should also be reviewed and audited. Routine hand hygiene and ongoing monitoring of staff adherence to hand hygiene remains one of the single most important aspects of presenting and responding to MDROs. You should also ask your housekeeping staff to perform enhanced environmental cleaning, especially of high-touch surfaces, and audit environmental cleaning. Also, use designated or disposable equipment for the patient with an MDRO, and notify facilities upon transfer, both verbally and in writing if the patient transfers. Finally, you should make a point to educate staff, visitors, residents, and families about MDROs. We encourage you to consult with us at MDPH at 617-983-6800 about developing an appropriate infection prevention plan for the resident. I wanted to briefly mention that we have summarized these infection control recommendations that I just mentioned for skilled nursing facilities into a one-pager, which we will send out shortly after the call. Now I'm going to turn it over to my colleague, Melissa Cumming, who is going to review the use of personal protective equipment in more detail, as well as CDC's new enhanced barrier precautions.
Great. Thanks so much, Amy. So now we're going to move on to a discussion of enhanced barrier precautions, or EBP. CDC issued guidance for enhanced barrier precautions last year for use as part of the containment response to a targeted MDRO in a long-term care facility. A primary driver for the development of EBP was the fact that use of contact precautions can certainly create challenges for nursing homes trying to balance the use of those precautions and room restriction to prevent MDRO transmission with a resident's quality of life. We're aware that this has led many nursing homes to implement contact precautions only when a resident is actively infected, not merely colonized with an MDRO, with removal of contact precautions when treatment is completed. However, focusing only on residents with active infection fails to address the continued risk of transmission from residents with MDRO colonization, which can persist for long periods of time and result in the silent spread of MDROs, as Amy discussed earlier. There is also growing evidence that implementation of contact precautions in nursing homes for only those with active MDRO infections is simply not adequate for prevention of MDRO transmission. And we've unfortunately observed that here in Massachusetts. And in those facilities that implement contact precautions also for colonized residents, we know that quality of life is a concern because these residents are oftentimes in a facility for a very long period of time. So on this slide, you'll see a link to the CDC page where the full guidance sits, as well as a number of associated resources, including a frequently asked questions document, which is really excellent in answering many of the most common questions associated with EBP. All of these resources will be provided to you after the presentation. So EBP, or Enhanced Barrier Precautions, expands the use of personal protective equipment beyond only those situations where exposure to blood and body fluids can be anticipated, as currently stated under standard precautions. EBP refers specifically to the use of gown and gloves during high contact resident care activities that we know pose the greatest opportunity for transfer of MDROs to staff hands and clothing. Now, what do we mean when we say high contact resident care activities? These would include the examples seen here on the slide, and this is clearly spelled out in the CDC EBP guidance. Many people have asked, for example, what does providing hygiene mean? This refers to practices such as brushing teeth and combing hair. These activities, along with many of these other high contact resident care activities, are generally bundled as part of morning and evening care for a resident, rather than occurring as multiple isolated interactions throughout the day. Therefore, isolated combing of a resident's hair that is not otherwise bundled with other high contact resident care activities would not generally necessitate use of a gown and gloves. However, if bundled with morning or evening care, we would recommend gown and gloves. In addition, activities such as simple med passes, blood glucose monitoring, or food service tray delivery would not require gown and gloves. So based on this guidance, gown and gloves are not required for resident care activities other than those listed above, unless otherwise necessary for adherence to standard precautions. Very importantly, with EBP, residents are not restricted to their rooms or limited from participation in group activities. They also do not require a private room. Now, for which residents should EBP be applied? Any resident with infection or colonization with a targeted MDRO for whom contact precautions do not apply. So a resident who does not meet the criteria for contact precautions, but is colonized or infected with one of the MDROs you see listed here, CRE, CRAB, CRPA, or any other Carbapenemase producing organism, they should be placed on EBP. And in addition to those residents colonized or infected with an MDRO, any resident on the same unit with a wound or indwelling medical device should also be placed on EBP. And this is where EBP is especially different from traditional contact precautions, because here we are extending protection and EBP to those on an at-risk unit who are most at risk of acquisition of an MDRO, not only those who are infected or colonized. When we say a high-risk area, we mean specifically a unit or floor where a patient known to be colonized or infected with a targeted MDRO resides. As an important reminder, contact precautions should be used for all residents infected or colonized with a targeted MDRO and presence of acute diarrhea, draining wounds, or other secretions or excretions that cannot be contained or covered. So any resident with those in place does require contact precautions. Also importantly, on a unit or in a facility where ongoing transmission is documented or suspected, contact precautions are indicated for those colonized or infected with a targeted MDRO, even if no wound or indwelling device is present, until there is evidence that transmission has been stopped. I also want to point out that there are a few other situations unrelated to targeted MDROs where contact precautions would still certainly apply. This would include C. difficile infection, scabies, and norovirus. And I think, as most are familiar, contact precautions under those circumstances are generally time limited. Just to take a step back and review what are targeted MDROs in Massachusetts. So what are the scenarios where we are going to be recommending EBP for use in long-term care facilities? These are the ones that Amy mentioned earlier. We're including Carbapenem resistant Enterobacteriaceae, Carbapenem resistant Acinetobacter baumannii, Carbapenem resistant Pseudomonas aeruginosa, Candida auris, and all other Carbapenemase producing organisms. So why did the CDC feel that EBP guidance was needed? And I alluded to this earlier, but I think it bears repeating that focusing only on residents with active infection really failed to address the continued risk of transmission from residents with MDRO colonization, which we now know can persist for very long periods of time and result in the silent spread of MDROs. So I think it was in the face of mounting evidence that this was determined. Facilities, we understand, needed an approach to gown and glove use that was less restrictive than contact precautions and could be sustained for prolonged periods of time, up to and including the duration of a resident's stay in a facility. EBP also addresses the care of residents who are most at risk for acquiring colonization by virtue of residing on a unit where a known colonized or infected individual is residing as well. EBP does offer more flexibility, while at the same time more protection for those residents at highest risk of acquisition of these organisms. EBP is effectively a combination of elements of standard and contact precautions, and many think of it as sitting along a continuum between standard and contact precautions. Now we're going to walk through a scenario that occurred in Massachusetts. It took place somewhat recently, and we have changed any identifying details, but this essentially is based on an actual case that occurred here. So we have an 82-year-old woman who we'll call resident A, who resides on your long-term care unit. She develops a symptomatic UTI. She has no wounds or indwelling devices. You send a urine culture for testing, and your lab reports back that it is positive for E. coli. A few days later, you get a susceptibility test report indicating that the E. coli is in fact resistant to meropenem. So what does resident A have? Right now, as far as we know, resident A has a CRE, a Carbapenem resistant Enterobacteriaceae. So what would your next steps be? It's important with this information to place this resident and any high-risk residents on her unit on enhanced barrier precautions. Also important to notify receiving facilities if she transfers both verbally and in writing. And this includes even a transfer to the emergency department that does not result in an admission. Dedicate equipment to the resident who has CRE in her urine. Review and audit hand hygiene, environmental cleaning, and PPE with staff on the unit. Notify and educate all staff, residents, and families about CRE, and also notify the Department of Public Health. Your lab most likely automatically reports these results to us at the health department, and it is very likely that we would already be reaching out to your facility at this point. But in the event you receive a result such as this and have not heard from us in the epidemiology program, please reach out. Once we receive this information from your laboratory, we then request the isolate be sent to the Department of Public Health laboratory for Carbapenemase testing. Now just to take a look at which residents should be managed with EBP based on what we know now on this unit. We've selected just a few sample residents here just to highlight some differences. So hopefully, as you can all see here, EBP would in fact be indicated for resident A, who we have established has CRE in her urine, but she has no wounds or indwelling devices, so EBP is appropriate. For residents D and G, who both have a risk factor for acquisition of an MDRO and now reside on an at-risk unit because of resident A, we also recommend EBP for them. Now, it's important to realize that if resident D's wound heals or resident G's Foley catheter is removed, they no longer would need to be managed with EBP, and those precautions could be removed for those residents. The State Health Department laboratory performs additional testing on the isolate, and it is found to be positive for carbapenemase production, and specifically for the gene target NDM, which we all know now tells the organism to produce a carbapenemase. I've highlighted on the right where we are in this process. So now that we know this, what do we know that resident A has? Because the E. coli was positive for carbapenemase production and the NDM gene target was identified, we now can confirm that resident A has a CpCRE or carbapenemase producing CRE. So what different things would you do now at this point? It's important to continue all previously discussed infection control recommendations, including enhanced barrier precautions for the unit, staff education, and monitoring. You should also ensure enhanced environmental cleaning of the long-term care unit that resident A resides on. And then it's time to consult with the health department for further steps. The next steps are likely to include screening of contacts for NDM colonization, and this is done through rectal swabs, as well as an on-site infection control and response assessment at your facility. Since resident A was not previously on any precautions before her CRE was identified, a screening survey of all residents on the unit is indicated based on CDC guidelines. The health department will work with you to send the supplies and coordinate testing. This testing is performed at our regional public health laboratory in New York and is all performed free of charge. So after consulting with the health department and facilitating screening of your long-term care unit, unfortunately, 2 additional patients tested positive for NDM colonization. Important to stress, these individuals are colonized, not infected. These organisms were identified by testing rectal swabs. However, although they are only colonized, infection control precautions are in fact indicated for them. Because transmission on this facility is now documented and potentially still ongoing, any colonized or infected patients should be placed on contact precautions, not only EBP, as we mentioned earlier. The other at-risk residents on the unit can remain on EBP. Remember, ongoing transmission is a circumstance we mentioned where contact precautions are indicated for colonized or infected individuals. And here on this slide, we've highlighted examples of available door signage that's available on the CDC website, and we strongly encourage their use, especially in a facility where both EBP and contact precautions will be used, because you can see there are some distinct differences in the signs, and they're easily downloadable from the CDC site. So back to our unit. Now, with additional information about potential ongoing transmission, which residents should be managed with EBP and which should be transferred to contact precautions. So now, because ongoing transmission is suspected, we are going to place any resident colonized or infected with NDM E. coli on contact precautions. So that's going to include residents A, B, and D. B and D are the residents who are identified as being colonized through screening. As you can see, again, EBP is still appropriate for those on the unit who are at risk of acquisition, but not colonized or infected with the MDRO. And that would be resident G. And as mentioned earlier, again, even under these circumstances, if resident G's Foley catheter were removed, EBP would no longer be indicated for that resident. Now, just to take a step back, I just wanted to review briefly, how does screening happen? So if you're in a facility where a case such as resident A is identified and screening is recommended, we just wanted to walk you through some of the steps. So if this resident is identified in your facility, as mentioned, epidemiologists from the health department here in our division will work with you to determine if colonization screening is indicated. And generally, if a colonized or infected resident had a roommate or a bathroom mate or was not on precautions in the 30 days prior to identification of the MDRO positive culture, then some colonization screening of contacts in the facility is likely to be recommended. And generally, we look at the unit that the resident was on, and we look at shared healthcare exposures as well as any shared equipment. We will work with our regional antibiotic resistance lab network partner, which is the Wadsworth Laboratory in New York. They will overnight FedEx swabs and shipping supplies to your facility. Included with those supplies will be all return shipping materials. And we will keep you looped in to shipping information, including tracking numbers, once those materials are shipped to you. We will have an email chain going, so you'll be aware of when to expect those supplies. In general, when contact screening is indicated for suspected transmission, we require 2 negative colonization screenings of an affected unit collected at least 2 weeks apart in order to have sufficient evidence that transmission is no longer ongoing in a facility. So in this facility, our example facility, after 2 negative screening surveys, I just wanted to highlight what can change about precaution recommendations. So after the 2 negative screening surveys, we can now say with some degree of confidence that ongoing transmission is not likely to still be occurring. Once that is the case, those residents with MDRO, colonization, or infection can be managed with EBP instead of contact precautions, again, if they do not have active acute diarrhea, draining wounds, or other secretions or excretions that cannot be contained. So you can see here the change would be for residents A and B. For resident D, however, because that individual still has a draining wound, contact precautions are still indicated. If that draining wound heals, resident D can be transitioned back to EBP. So now, before we get to questions, which we welcome. I just wanted to highlight some important MDRO and infection control resources that you have at your disposal. We will, of course, be sending references and links to all of these out to you after the webinar today. The State Health Department website has quite a lot of information available regarding infection control and basic information on CRE and other MDROs. Most of you are probably familiar with our CRE toolkit, which has just been updated and is going to be released imminently. We have renamed it an MDRO toolkit. So this will be our 2020 MDRO toolkit, which will cover all of the targeted MDROs that we've discussed today, and also incorporate recommendations for enhanced barrier precautions. And as soon as that is released, we will be sending it out to everyone registered for this webinar. We also have general resources for infection prevention and control for long-term care that includes organisms and conditions other than targeted MDROs, and those can also be found on the website here. There are also a number of really great resources on the CDC website, especially when talking about enhanced barrier precautions. And as we mentioned, the FAQs there, I think, are very useful. You can also find examples of all of the door signs that we displayed during the presentation there that you can readily download and use in your facility. And so with that, I think I will turn things back over to Kate and Alyssa to moderate any questions.
Sorry about that. I think I clicked mute on you. This is Kate, and I just added the option for everyone to unmute their lines. If you are on the phone only and you would like to ask a question over the phone, press *6 to unmute yourself. And then when you're done asking a question, you can press *6 again to re-mute yourself while we wait for people to ask questions over the phone. And if you aren't on the phone and want to unmute yourself, there's simply, if you look on your screen, there should be a mute or unmute microphone or phone in the bottom left corner. That works as well. Only people who are on the phone alone need to hit the *6 button. So while we wait for questions to come in over the phone, I see a few already in chat. Alyssa, would you do me the favor of announcing them?
Of course. So our first question here from Anne says, resident A admitted with a history of CRE 2018 is not symptomatic. Would EBP be required? Does that make sense, Melissa?
Yes.
Okay.
And the answer is yes. Unfortunately, once a resident is identified as being colonized or infected with a CRE, the presumption is they are potentially colonized for years, if not longer. And so we do recommend EBP in this case.
Great. And
hi, it's Amy. I also wanted to add that actually this outbreak happened in, this is a real life example of an outbreak, and actually the reason it did happen was because resident A was asymptomatic, and so it was taken off of the appropriate precautions, but still, even though they were asymptomatic, clearly spread this organism to others in the facility.
good to know. Thanks for sharing. The second question comes from Paula. Are EBP recommended for MRSA colonized patients?
No.
That's a good question, Paula. So at this time, CDC does not recommend EBP for MRSA colonized patients. A facility could choose to use EBP for any organism that they feel is epidemiologically important in that facility. So for example, if you were a facility dealing with a MRSA outbreak or a number of invasive cases, it might be a consideration, and that would be something that we could discuss with you. But generally speaking, EBP is really intended for use for these targeted MDROs.
Sounds good. The next question is a little longer in chat from Mary Jane, and she says, hi, I have a resident with CRE that was diagnosed more than 6 months ago and has been on contact precautions. I did do one reculture, which was sent to New York and was in fact negative. I was told there is not a recommendation to reculture, so the second wasn't done. Should I get another culture for 2 negatives so that I can use enhanced precautions?
Hi, Mary Jane. Thanks for that question. I know exactly the case you're talking about. That's a good question. So the answer is no, you do not need to reculture. When we talk about 2 negatives, we're actually talking about 2 negative rounds of facility-wide screening. We're not talking about 2 negatives for an individual resident. So in the case that you describe, your resident could be placed on EBP if there was no other reason to maintain them on contact precautions, such as acute diarrhea, a draining wound, or secretions or excretions that could not be contained. So that patient would be very appropriate for EBP, as well as anyone else on that unit who has a wound or an indwelling device.
Sounds good. So the next question from Cheryl is, can the resident who is on EBP precautions use the same toilet as their roommate?
Hi, Cheryl. Thanks for the question. Yes, so EBP differs from contact precautions in that residents are not confined to their rooms, and yes, they can remain in the same rooms as their roommates and use the same toilet.
Good. And there's a question from Rose about the signs listed on the website, that they seem to contain quite a bit of information on them, and wondering if they violate patients' right to privacy or HIPAA.
That's a great question and a very common question. So CDC has actually done quite extensive review and research on this specific topic. There's no diagnostic information on the sign whatsoever. It's just a recommendation of precautions that staff should take to protect both staff and other patients. And I think as EBP, the use of EBP expands more widely, I think it'll probably become, a much more common sight to people, but it does not violate HIPAA.
Sounds good. And I don't see any further questions in the chat right now. So I would like to see if anyone has a question on the phone line. Is anyone waiting to jump in? All right, well, doesn't sound like we have any questions on the phone line either. So seems like we answered all the main ones. Kate, do you want to jump back in to do the closing for us?
Can you hear me now?
There you are.
Oh, thank you. All right. So sorry about that. If you think of any questions while I'm talking, feel free to interrupt me. I was just telling everyone that we are going to close the webinar momentarily. Everyone will be receiving a follow-up email with a link to the survey. If you have not yet, if you don't have the ability currently to take the survey, which will be posted in chat, that link will be in the follow-up email, and as soon as the recording, transcript, and presentation have been uploaded, that will also be included to everyone here in a follow-up email. This morning, everyone should have received an email with a link to the presentation and also to the additional resources. That resource that was mentioned in the slides today will be in that follow-up email that will go out shortly. So before we close out, last chance for anyone who has any questions. And Melissa or Amy, do you have any closing remarks?
I don't think so.
Can you hear me?
Oh, go ahead.
Hello?
Yes, go ahead.
Okay, so say I have a patient and they came back ESBL positive, so we treated them, put them on contact precautions, and so they went a second time, got treated, and the nurse practitioner or the doctor colonizes them. Then we take them off precautions. Is that wrong? Should they remain on precautions?
So I think that taking an ESBL colonized patient off of precautions is something that we see pretty consistently in a lot of facilities, including acute care facilities. So the recommendations that we discussed today, in particular EBP and the examples of contact precautions, are really for targeted MDROs, those that we described, which does not include ESBL. So
Okay.
I think in the case of an ESBL colonized patient, I think, you know, thinking about transmission-based precautions and, you know, knowing that the infection is adequately treated and keeping in mind, you know, the type of activities, you know, that the healthcare worker's going to be, you know, providing to the patient, and just, you know, using precautions as appropriate for those activities makes sense. But I think that what you describe is somewhat consistent and something that we do see in a lot of facilities. And so I wouldn't necessarily say it's wrong.
Okay, thank you.
Sure. Kate, I would just add that Amy and I are happy to share our email with the information that goes out, and anyone who thinks of a question after the fact, or maybe after you've started to look at the EBP guidance more closely, if you have specific questions, we're always happy to answer any questions by email.
Sounds great. Thanks so much. Barring any further questions, I will hang up the line in just one more minute. I feel like folks are coming in a little late with those questions, so I want to make sure we're not closing anybody off.
Just one last question in chat. So no precautions are needed for colonized MRSA or VRE.
Yeah, thanks, Alyssa. So that question, I think, can be managed similar to the ESBL question that we just had. So the infection control guidance and recommendations for long-term care facilities that we currently have up on our website really does get at the, you know, sort of, is the patient wet, or are there uncontained secretions? Is there active infection? And if the answer to all of those are no, then precautions probably are not indicated beyond standard precautions, or, you know, precautions appropriate to the activity at hand. So I think that's been pretty consistently applied across facilities, and that would be for these non-targeted MDROs, including MRSA, VRE, and ESBL. But the one thing I will say is, as a facility, it's really important to have your own facility guidelines around all of these examples, and to make sure that you're following those facility guidelines. There might be facilities that specialize in wound care, and maybe in a facility such as that, you know, different recommendations might be appropriate. So I think it's important to, you know, make sure you've got a facility-specific policy for all of these examples. But I think, you know, once active infection has ceased, there's no longer, you know, draining wounds or secretions or excretions that can't be contained, then I think it would, in many cases, be fine to not use contact precautions.
Thank you. Any other questions on the line before we hang up? All right, thanks so much. Again, the evaluation link was posted in chat, and you'll all be receiving a follow-up email. Thanks so much for joining us today, and have a great week.